Sympatholytics are pharmacological agents that function by inhibiting or lysing the activity of the sympathetic nervous system. They achieve this by blocking sympathetic nerve stimulation or by blocking the effects of externally administered agonists, such as isoproterenol. There are three primary mechanisms used to achieve sympatholysis. First, adrenergic receptor antagonists. These drugs bind directly to receptors on target tissues. This binding prevents norepinephrine or other sympathomimetic drugs from attaching to the receptor. This group will be our primary focus today. Second, central alpha-2 agonists. These agents act within the brainstem, specifically the medullary vasomotor center. By stimulating presynaptic alpha-2 receptors, they activate inhibitory pathways that reduce the sympathetic signals sent from the brain to the rest of the body. While they are technically agonists, their physiological effect is sympatholysis because they provide negative feedback. They essentially trick the brain into thinking there is already enough norepinephrine, which inhibits further release into the synaptic cleft. And third, adrenergic neuronal blockers. These drugs do not act on receptors. Instead, they enter the sympathetic nerve terminal and disrupt the internal life cycle of norepinephrine by inhibiting its synthesis, storage, or release. These are often considered clinically obsolete because modern drugs target receptors much more precisely with fewer side effects. Moving on to our main topic, adrenergic receptor antagonists, the alpha and beta blockers. Most of these agents are reversible, meaning they are competitive antagonists. The exception is phenoxybenzamine, which is an irreversible antagonist. To understand how these blockers work, we must first look at what happens during sympathetic stimulation. Think of it this way. Tissues that are useful under stress get stimulated. Muscles contract, sphincters constrict, vessels constrict, and glands increase secretion. These are the responses of effector organs that help you fight or flight. Conversely, tissues that aren't immediately helpful for survival, like digestion, are inhibited. Muscles relax, sphincters relax, vessels dilate, and glands cut back on secretion. Here is the rule. All the helpful organs have alpha-1 receptors, except for the heart, the juxtaglomerular apparatus, and the pineal gland, which use beta-1. All the organs that are inhibited have beta-2 receptors, except presynaptic nerve endings, platelets, and some parts of GIT, which use alpha-1. Beta-3 receptors are found specifically on the urinary bladder and adipose tissue. For example, alpha-1 receptors are found on smooth muscles and cause blood vessels to constrict to increase blood pressure. When you block them, you remove that constriction, resulting in vasodilation. Beta-1 receptors are found on the heart and juxtaglomerular cells. Agonists increase heart contraction and renin release, which triggers the RAAS system to hold onto water. So blockers will do the opposite, slowing the heart and reducing fluid retention. Looking at the classification of adrenergic blockers, we have alpha blockers and beta blockers. Alpha blockers are further divided into three types. Let's look at non-selective alpha blockers. These agents block both alpha-1 and alpha-2. Phenoxybenzamine forms a covalent bond with the receptor, making it irreversible. Because it physically locks the receptor, the body can only overcome the blockade by synthesizing entirely new receptors. This is why it is the standard for the preoperative management of pheochromocytoma. It prevents a massive sudden surge of adrenaline during surgery from overcoming the drug and causing a stroke. Phentolamine is a reversible competitive blocker. It is used as an antidote for extravasation. If a potent vasoconstrictor, like norepinephrine, leaks out of the vein into the skin, phentolamine is injected to force the vessels back open, preventing tissue death or necrosis. Next, selective alpha-1 blockers. These drugs end in the suffix -osin. The azosins, prazosin, doxazosin, and terazosin are used for hypertension. By blocking alpha-1 on the smooth muscle of both arteries and veins, they decrease peripheral resistance. For prostate selectivity, tamsulosin, alfuzosin, and silodosin target the alpha-1A receptors found in the bladder neck and prostate. This relaxes the smooth muscle in the urinary tract without affecting the blood vessels as much, which is why they have fewer cardiovascular side effects. Regarding pharmacokinetics, doxazosin is the longest acting and is excreted via feces, while others go through the urine. Prazosin is typically used with a diuretic because the body senses the drop in blood pressure and tries to compensate by retaining sodium and water. Finally, watch out for first dose syncope. This is a fainting spell that occurs when a patient stands up. Normally, alpha receptors would constrict your leg vessels to push blood up to your brain. When they are blocked, gravity pulls the blood down, and your brain temporarily loses pressure. This risk is higher with Azosins and lower with tamsulosin because it doesn't block the vascular receptors as strongly. Now, alpha-2 blockers. These receptors act as a brake on the system. Blocking them removes this brake and forces the brain to release more norepinephrine. This actually increases sympathetic activity, which is why they are rarely used in general medicine. Examples include yohimbine, used in research, or mirtazapine, which is an atypical antidepressant that works by increasing neurotransmitter release. Section 3. Beta blockers. Known as the Olols, these are used for hypertension, angina, and arrhythmias. Blocking beta-1 leads to decreased heart rate and cardiac output. However, blocking beta-2 in the lungs and liver can cause bronchospasm and the inhibition of glucose production. Beta blockers are classified into generations. First-generation drugs are non-selective, blocking both beta-1 and beta-2. Examples include propranolol, pindolol, penbutalol, timolol, sotalol, levobunolol, metipranolol. Mnemonic. Please pretend politely till someone loves me. Because they block beta-2 in the lungs, they can cause the airway to tighten, making them contraindicated in patients with asthma or COPD. Second-generation drugs are cardioselective, targeting beta-1. Examples include atenolol, bisoprolol, esmolol, acebutolol, and metoprolol. Use the mnemonic ABEAM to remember them. Because they ignore the beta-2 receptors in the lungs and liver, they are safer for patients with respiratory issues or diabetes. Third-generation drugs can be non-selective, like carvedilol and labetalol, which also provide alpha blockade to further lower blood pressure, or cardioselective, like nebivolol, which triggers nitric oxide release to help dilate the vessels. Therapeutic uses are broad. 1. Hypertension, by lowering cardiac output and renin. 2. Glaucoma. Timolol decreases the production of aqueous humor, lowering the pressure inside the eye. 3. Migraine prevention, by preventing excessive vasodilation in the brain. 4. Myocardial infarction, by reducing the heart's workload and oxygen demand. Note, beta blockers must never be stopped abruptly due to receptor upregulation. When you block receptors for a long time, the body grows more receptors to try and catch a signal. If you take the drug away suddenly, the body's natural adrenaline hits an army of receptors, causing a massive rebound spike in blood pressure. Specialized beta blockers include mixed blockers like carvedilol, which prevents cardiac remodeling, where the heart gets floppy and large after an injury, and labetalol, the drug of choice in hypertensive crises because it can be given via IV for immediate effect. We also have intrinsic sympathomimetic activity drugs like acebutolol. These are partial agonists. They block the receptor from big adrenaline surges but provide a tiny bit of background stimulation, so the heart rate doesn't drop too low while the patient is sleeping. Regarding toxicity, glucagon is the antidote for overdose. It works by binding to its own specific receptors, which use a different pathway to increase heart rate, completely bypassing the blocked beta-1 receptors. To summarize the contraindications, alpha blockers should be avoided in decreased coronary perfusion because the resulting reflex tachycardia, where the heart beats faster to make up for low pressure, makes the heart work too hard and can trigger a heart attack. Selective alpha-1 blockers like prazosin should not be used as monotherapy in heart failure because of sodium and water retention. All beta blockers should be used with caution in diabetes because beta-2 blockade stops the liver from releasing glucose during a sugar crash and masks the tachycardia that usually warns a patient their sugar is low. Non-selective beta blockers are contraindicated in asthma because blocking beta-2 causes the airways to constrict. Finally, remember these clinical pearls. First, glaucoma. While beta blockers are the treatment of choice for chronic management, they aren't used for emergencies. For acute angle closure glaucoma, the drug of choice is actually pilocarpine, which is a cholinergic agonist, not a beta blocker. It works by a different mechanism to quickly constrict the pupil and open up the drainage angle. Second, hypertensive emergencies. Reach for labetalol in its IV form for rapid control. Third, pheochromocytoma. You must use Phenoxybenzamine preoperatively to prevent a catecholamine-induced crisis. And fourth, vasopressor extravasation. Use Phentolamine to reverse localized vasoconstriction and save the tissue from necrosis.